Now, innovation really is not invented in the United States. Innovation, as you know, comes everywhere. And certainly what I've observed is that necessity is the mother of invention. When you go to resource-poor countries, there are a lot of innovators who come up with greater ideas of doing things that we may not do because we are paid the way we've been paying. You know, we are quite comfortable doing things. And so when you look at innovation, on the left side is, in fact, MIT Hackathon. And we have in Durham, in fact, an American Underground where people, software guys, are working on healthcare. To this side where I show you, in fact, a village in Africa. What I want to tell you a little bit about is how one can take this global ideas of innovation and to try to learn as we also try to teach. You know, for a long time, people think about globalization is Americanization. We go out there to help people, to teach them things, but I can tell you that myself being a product of globalization born in China and having traveled, we can learn a lot from other people who are solving their problem in different ways. So about 4 years ago, I launched a new entity at 501c3 called International Partnership for Innovative Health Delivery. And my partners were McKinsey and the World Economic Forum in Davos. We launched this because as I was leading a project looking at these innovators, it became very clear there's a huge network of innovators out there, and you can learn a lot from them. And this is only partially. We were supported by Robert Wood Johnson Foundation, Rockefeller, and many industry for us to map this innovators, to learn, see what they do, and to see what are the lessons learned. And you may hear from David Blumenfeld, the Commonwealth Fund is going the same direction now, to say what, in fact, can we reverse innovate, using the word loosely. So among the things we did is because we went on tours, study tours, in this case in India, looking at Narayana Heart hospitals. This is a hospital that operates for the last 20 years, founded by a visionary, Devi Shetty, a cardiac surgeon trained here. For the last 20 years have actually kept the cost of open heart surgery $3,000 a year. And what do we pay here? $50,000, $100,000? And Narayana Hospital is now very extensive. And if you go and talk to the people, it's a culture. It's a culture of everyone in the front line saying, we need to keep the cost down, we need to improve quality, because they recognize their neighbors can't afford the care. So how do you afford the care for places like India, where people don't have the means? Importantly, Narayana has actually, as you know, gone to partner with Essentia Health to actually start a hospital in Cayman Islands. So medical tourism reverse is coming to us. When you think about, you get the same quality CMI, JCI accredited, and you get such costs, I think we need to understand that the payers at some point are going to say, you know what, we're going to sign up with them rather than sign up with Duke or whoever, right? So what we've learned in a snapshot of examples of Narayana Health hospitals, the LV Prasad and also Aravind Eye, where they do cataract surgery, $10 to $20 per surgery, cataract surgery, versus $3,000 here. What they do is they have a conveyor belt pipeline. You know, they do 250,000 cataract surgery a year because it's simple surgery. If you know cataract surgery, it doesn't take that long. It's 10, 20 minutes. And you know, it doesn't take a highly specialized retinal surgeon to do it. And so I've been trying to drive this at Duke to say, let's try to start doing this. It's what Clay Christian said about Focus Factory, right? And of course, LifeSpring hospitals offer low-cost maternal child services, 1/4 the standard fees, and Vatsala is a primary care network of rural hospitals that can allow people to access this care. What we have done at Duke is that we actually got a big grant from USAID, and we created a social entrepreneurial program which allows us to bring together under IPRG these networks, but also begin to help develop business models, help them do financing, help them overcome regulatory issues, and also train many of the students who are trained in global health and business school for the future. So if you look at their categories of innovation, as already talked about, it's the same categories as we've been talking about, except they've been able to put into practice. So what have we learned from these global innovators? Well, first, we've learned that here too. It's the community, getting closer to the patient. You don't have to come to the big white halls and ivory towers. It should be looking at their behavioral patterns, distribution, low distribution costs, and of course, as Paul and others have shown, that if you look at taking drugs for TB, just DOTS program, observing the patients taking drugs at home, is going to increase the compliance. Reinventing delivery model by using technology, cell phone, telemedicine, many others. Confront assumptions, right skilling, task shifting workforce, I just told you about, how to use, in fact, all the health professions effectively. Standardization, reducing variation. Borrow someone's assets. In other words, reduce your fixed costs as much as possible, and of course, open new revenue streams. So I think a big part of what we at Duke are doing, and I know there's been a lot of conversation now, is to say, how do we import these innovations as models that's been proven to be useful, and how do we do what people call reverse innovation, which I think is a wrong term, is really importing innovation and embrace solutions that's not invented here. Now, there are many barriers, to be sure. I mean, immediately you would tell me about the potential of litigation, if this is not the standard of care, and then how do we change the way we do things? So part of the ecosystem is to create pilot programs. And I've been talking to Peggy Hamburg of doing very similar to, say, if you have a new drug, which you can give informed consent and do under safe harbor, testing new ways. And at the end, if you show you can save dollars and improve health, you ought to adopt it. And that will allow us to leapfrog a lot of ideas that would not be easily adapted here. So a big issue I'd like to end by talking about is driving innovation from within. In other words, everybody has to be thinking that I can make a difference. I heard the story, and I don't know whether it's correct or not, but I do want to attribute and give accolade to my friend Toby Cosgrove when he or somebody went and walked into the operating room at the end of the night, and the janitor was cleaning, and he said to janitor, "What are you doing?" He said, "I'm saving lives." So that's the way that you need to think. If people can all contribute to the solutions in an organized way, then I think we come up with 1,000 good ideas that can drive changes. And we need people to think about how to do things better. And what I like to do is to say, how do we enable most of us and many people to be innovators? Well, if you look at how innovation management, we have to have a strategy. And I would argue that most of our healthcare delivery systems don't have much of a strategy or innovation. We have to have the ability to generate new ideas, screen new ideas, and in fact, develop a concept, and I would say implementation. Here it says commercialization. What that means is that we have to have a system, a culture, an ecosystem of innovation. You can pop up with new ideas, but how often have I run into a physician who says, "I got this great idea, but I didn't know where to take it." And when I went to my service line manager, she says, "It's not in my budget. I can't do it." Right? Besides, you ruin my numbers. So we have to create an ecosystem and a way to support people who can have innovation and a way to help them screen and actually put it in such a way that can be systematic. And let me just say that there's systems engineering, there's business model, technology, workforce, and population health. So we've done a little bit of screening looking at what's happening across the country, and I apologize if I miss anybody. But my team had looked at that there's an emergence of many places now that have either a chief strategy officer, chief innovation officer, or an innovation institute or program. And the range is plotted in this graph, which shows you that some are very focused on care delivery and others on commercialization of discoveries that can actually, and of course, there's a whole spectrum. I think the ones in the middle I want to point out to you about Ariadne Labs, that's Atul Gawande's lab, where he brings people together to talk about areas of clinical needs and bring solutions together. And at Duke, I launched a Duke Institute for Health Innovation, which is embedded within the health system, but connected with the rest of the university. So we can bring in all the great minds, but the questions are generated by providers within the health system, by their observation. So we have 4 pillars: implementation, healthcare delivery, technology, development of workforce and leadership, and of course, applied policy that can influence the way innovation can move forward. And so important thing is, in any of the health systems and practices, you have to create a framework by which you can say, how do I identify the opportunities? How do I gather the facts? What, in fact, is the best practice out there? What are new ideas? How do I find resources? How to deploy solutions? How do I monitor whether it's successful or not? And how do I share and disseminate the learnings? So that's the framework that we put together at Duke. And importantly, what we end up doing is creating this institute where it's inclusive with central staff and others, but also welcoming, where we have office hours. We just hold office hours when people come and say, got an idea, and of course we reach out to the community in the software engineer community to have them come together. From system engineering committee, we held workshops around specific topics of areas need for solution. We create a RFA, request for application, that have people apply, and we support new innovative ideas. And also, at some point, the big ones, it becomes into priority to take larger initiatives to move things forward. So I want to end by saying that you have to democratize innovation by making everybody feel there's really support, there's, in fact, it's accessible, that we are listening to everyone, that there's cooperation, that you teach innovation, that in fact you support the idea of moving it forward, and you take bets on people and ideas. This is a Mayo Clinic Innovation Center. They have done under Nick LaRusso the idea of creating a place where they can have demonstrations and ideas coming together so that when you want a new workflow, you can try that out. So I think that's really important, but also protecting the time. In Google, people are hired 80% for the day job, and they get 20% protected to be able to innovate. Now, we can't do that in healthcare to everybody, but there should be people who are particularly innovators who should be given that protected time, being able to practice and being able to come with new ideas. Space and money, and of course, support. And to make that information accessible and to teach innovation, you'll be surprised when people say, well, that's really intuitive. It's not quite true, because if you look at how we teach medical students, we have a hierarchical organization where, certainly in my days, I don't challenge the professor. Whether he's right or wrong, we have to let people think about new ways and challenge the standard paradigm. And of course, importantly, as I mentioned earlier, we need to start training our next generation. So high-value, cost-conscious care curriculum is now being implemented in many places. Certainly in my previous organization, Duke, we're now having residents coming together to be able to measure the performance, to look at, in fact, being conscious of what they order and how, in fact, it has any outcomes or cost issues. And importantly, we also have an innovation fund that I created that, in fact, allow people on an annual basis to come up with new ideas from residence level. And the UCSF, they have something like that as well. We teach them management leadership. You heard about our GME report, and we also have a report on interprofessional education. So many of the things that IOM does, we're hoping to also continue to push forward some of these ideas. And of course, giving a place for learning health system, you can see we have published a whole series of what is needed for innovation and continuous improvement in health and healthcare. And of course, ideas of Cleveland Clinic spin-off, commercialization, supporting some of these great innovations, and bet on people. I would say to you, I've been very fortunate because I work at the then Peterborough Brigham Hospital and then Brigham Women's, and my mentor, Jim Brownwell, took a bet on me, a young man from Asia. And I know that so many of my colleagues, Jeff Drazen is one of my classmates, and many others, at Benz, you name it, have all been actually because he took a bet on us. We got to bet on people, and this hackathon at MIT bets on ideas and people. So what's in the future? I think the CMI would say we need to move more to a value-based system, increase into alternate payment models, invest in tools and capacity for change. I just talked about that. Information to drive change, more information. Clinicians to engage, as I talked about. And they have turned to us in his slide that IOM is a trusted source. So what I want to do is end up telling you about one very short, briefly, about the roundtables that we have. We have a value, science-driven healthcare, where our mission is to bring together the leading minds of people to say what's the best evidence on point of care, what's real-time discovery, and how can we assure innovation, quality, safety, and care. And so we have, in fact, different groups to look at what's best practice in health professions, clinical effectiveness research, digital learning, evidence of communication, systems engineering, and value incentives. And of course, our domain priorities are science, value, and culture. Really looking at developing the evidence, how to give incentive, transparency, and how to get people to work together to create culture of one patient, one team. The tools that we have are things such as policy, leadership, and tools, which I won't have time going to, but look at our roundtable members. We have, in fact, from CMS, from VA, from NIH, from payers, from providers, from all walks coming together to talk about how we can move the agenda of value and science-driven healthcare with innovation forward. So I'd like to end this last slide to say, where are we going? As the new president of the Institute of Medicine, what I'd like to do is to work with all of you to say, what are our needs for this nation? What do you think do we need to do? And maybe articulate those things in the form of grand challenges in health and medicine for our next decade. I'm going through a year's worth of work. As I said, I'm making my listening tour. I started in San Francisco. I'm here. I'll be in New York City. I hope to go to many other places to engage conversations, not only with academicians, but in fact with people like yourself. Gary Gottlieb is putting together a meeting for me at the end of this month. I come back to Boston to meet with community care leaders. Last week, I was in San Francisco meeting with San Francisco Health Improvement Program, where it's a public-private partnership. They brought together not only the providers, but Department of Health, HUD, education, and also many NGOs together to improve the health of the community. We at IOM stand ready to be supportive. I find what I do at Washington in thinking policies and advising HHS, HRSA, and Department of Education is, in fact, trying to serve the same things that you're trying to do on the ground. So I should obviously listen to all of you and do my best to make a difference. Thank you very much.